CT venography suffers again from requiring contrast or dye administration, which may damage kidneys, and from a significant radiation dose. And it also suffers from only basically providing you with static imaging without sort of direction of flow. Conventional venography, an invasive procedure requiring a needle entry into the venous system at the groin or in the neck or in the arm, then catheter and wire insertion. Again, radiation and contrast is used. In terms of venography, technique is crucial. So you have to take into account where you are injecting your dye, the volume of dye you're injecting, how the patient is positioned and how the patient is moving or breathing, and the timing of your imaging. But it does provide the greatest anatomic detail and the greatest information about patterns of flow. There is potential for damage to the venous system, perforation with catheter or wire, dissection, venous spasm, which may be unremitting. But there's also the potential to intervene. In the cardiology world, we talk about an oculostenotic reflex. So if you identify a narrowing in a coronary artery, there's a tendency to want to open it up. The same thing may be at play here. So we see lesions. We really need to consider whether or not, weighing risks and benefit to the individual patient, these lesions should be opened. The risks of venous intervention are generally very small. Certainly it is a safer territory to work in than the arterial system. And basically what can we do in the case of venous narrowings? We can angioplasty or venoplasty them using a balloon. Venous lesions tend to show a lot of recoil, so even though they may open with the balloon, as soon as the balloon is removed, they tend to come back down to their original narrowed state. There's also a very high restenosis rate, so over the course of months, the stenosis may recur. There is a risk of rupture if you overdilate venous stenoses, leading to bleeding, and once you've dilated them, they may actually thrombose and close off completely. So that has brought around the use of stents, which are simply metallic meshwork tubes if you want to hold this elastic structure open. But stents have their own risks. In particular, they require anticoagulation, antiplatelet therapy with risks of bleeding to the patient. Stents tend to be expensive, costly. And again, there are risks of thrombosis, of stent migration in the venous system, and they do not prevent restenosis, so you can get re-narrowing through the stent. So before treating CCSVI, we need to address a lot of questions. Are these stenoses causally related to MS or simply a secondary association? Are there benefits to relieving stenoses? What we have heard of are general constitutional benefits, so patients who find that their fatigue is less, their brain fog has cleared up, they have a lot more energy, but we haven't heard a lot about benefit in symptoms related to specific plaques within the central nervous system, such as symptoms of ataxia or leg weakness. What are the short-term versus the long-term benefits, and what is the risk benefit to an individual patient? So the recommendation from me is for patients considering endovascular therapy, we should really only be doing this in a clinical trial setting and in institutions where there are experienced interventional radiologists or other specialists who can do this work, and where the interventionalist and the neurologist are working closely together and cooperatively. Thank you.